And immediately things changed for us. Part of the capitated agreement involved access to care, obviously, but also quality metrics that needed to be reported out. Quickly thereafter, we realized they were not meeting quality and we could not get access for our members. It seemed that every time a member called for an appointment, they were treated as third-class citizen. And that wasn't the case before. We continued to report it out to Desert Radiology, and what we found was that they did not want to meet any quality metrics and they wanted a fee-for-service deal. So we terminated our capitated deal and removed services from our health centers because they were the provider, and we ended up paying 115% of Medicare allowable. Only for a few months later, only to come back to renegotiations, and they wanted 225% Medicare allowable with 5% increases year 2 and 3. They insisted on a 3-year contract. Obviously, we did not go for that deal. We opened up our network, and we provided access to our members because it was becoming a continuity of care issue, and also just a reality that our patients were getting really upset. Clearly, private equity has a hold in Nevada. Another study in 2019 proved that 40 to 50% of services in anesthesia and emergency medicine are private equity owned or public traded or owned by public traded companies. Because of the negative impact private equity has had on driving up healthcare costs, cutting workforces, and harming quality, regulators and policymakers are taking action at the federal and state levels. The Federal Trade Commission filed a lawsuit last September against U.S. anesthesia partners, claiming the company had a scheme to roll up anesthesia practices in Texas in order to reduce competition and drive up prices and their profits. Last week, FTC, DOJ, and HHS announced a federal probe into private equity's impact on healthcare patients and affordability. Last December, Senators Grassley and Whitehouse announced a bipartisan investigation into private equity's impact on hospitals. State regulators. In February, the Colorado Attorney General resolved an investigation into U.S. anesthesia partners' anti-competitive business practice. USAP did not admit any wrongdoing, but will end contracts with 5 hospitals and completely end their non-compete agreement within the next 18 months. I'll leave it over to you, Mason. Yeah.
Thank you, Jesus. Good afternoon. I'm Mason Van Houweling, and I'm proud to say I'm the Chief Executive Officer of University Medical Center, the state's largest public hospital and academic teaching hospital in the state of Nevada. Across the nation and in Nevada, we continue to see negative impact of private equity firms in our healthcare system. UMC has experienced these challenges firsthand, with key long-term partners being acquired by private equity firms and subsequently demanding new contracts, exorbitant fees, and reduced services. Unfortunately, when private equity wins, Nevada patients lose, has been our experience. Nevada is not immune to this crisis, and the trend is alarming. And I can give you lots of examples, and my friend Jesus has mentioned anesthesia associates, radiology partners, but I'm going to talk to you about radiology in particular, but there's a lot of examples that are happening, but also will be happening in the future. As mentioned, our long-standing, most trusted local radiology partner was acquired by Radiology Partners, a national company backed by private equity and venture capital firms. In 2023, UMC received notice from Desert Radiology that the company planned to terminate its agreement with our healthcare system. This is how a UMC 58-year partnership with Desert Radiology came to a sudden and unfortunate end. Apparently, serving the community's most critically ill and injured patients is not profitable enough by the firms backing companies like Desert Radiology. In fact, I was looked at in the eyes by this company and told our 10% margins are not enough. We have to be at 20%. Nevada's prohibition on the corporate practice of medicine is at the heart of today's conversation and concern over private equity, along with the need to address non-compete and restricted covenant clauses. State restrictions throughout our country on the corporate practice of medicine are meant to protect patient and physician relationships, so decisions are made in the best interest of patients, not solely on corporate margins. At its core, this is what AB 11 in the last legislative session was all about. And you all did great work on that, and ultimately was vetoed by our governor. But 2 years later, the market is starting to feel the effects of what medicine run by faceless corporations can mean to patients, as well as healthcare providers looking to deliver that access to patient care, as Senator Donate mentioned on the opening of this committee on looking at access to care. Parties can disagree on when and where corporate practice of medicine restrictions should apply. And those same parties can work towards determining what exceptions to Nevada corporate practice of medicine should exist. However, all parties in this industry should be worried about how healthcare will be run by private equity, and it will further diminish access to care in our state. As many of you know, my advocacy on this matter has not been fully supported by some of my own colleagues. But I look, where will patients go in the future? And since we're in spring training and baseball, I'm going to use a little bit of a baseball analogy. Culinary Fund and organizations like UMC were first in the batter's box. But as the season progresses, hospitals, insurance companies, Medicaid ACOs, physician offices throughout our state will soon be impacted, squeezed, and held hostage. I truly feel, as we look back, we may look at a missed opportunity to lead and strengthen protection of our patients' affordability and quality, as private equity firms continue their endless pursuit of profits at the expense of our patients. At UMC and the team back at 1800 West Charleston, we fully remain committed to building a healthy future for our community and our industry by expanding access to life-changing care for Nevadans. Thank you, sir.
I believe there's another presentation from Families USA if they're ready to proceed before we go to questions.
We are. Just want to make sure you can hear us okay.
Please proceed.
Great. Good afternoon. Thank you all so much for this opportunity. We really appreciate the chance to come and talk with the committee today, and specifically Chair Donate. Thank you so much for the invitation and the opportunity to join the discussion. I just want to say quickly thank you to our fabulous partners at the Culinary Health Fund for your extraordinary work and partnership. And certainly Jesus and Mason, your comments today have both resonated with us. So thank you for the opportunity to join. I'm going to share my slides. I just want to make sure that you can all see them. So if for any reason you have trouble seeing them, please do let us know. I'm going to make sure this comes up. And I'll put this in presentation mode. Sorry. Oh. And there we go. Sorry, I was at the end. Let's go back to the beginning. Apologies. Okay. Present. Everybody can see that okay? I promise not to switch through my calendar and any number of other things you do not want to see while you're talking today. So my name is Jen Taylor. I'm the Senior Director here of Government Relations here at Families USA. As you said, I'm joined by my colleagues, Deputy Senior Director of Government Relations, Jane Sheehan, and Senior Policy Analyst, Aaron Plotke. In case you are not familiar with our organization, at Families USA, we've been a leading national nonpartisan voice for healthcare consumers, where we work to achieve our vision of a nation where the best health and healthcare are equally accessible and affordable to all. Key to that work is addressing our nation's healthcare affordability and quality crisis, which is fueled by our healthcare system's lack of transparency and healthy competition. So that's what we're going to focus on here today. My colleagues are going to talk you through most of the detail, and you already had a good up-close look at some of the challenges in Nevada. But before I hand things over to them, wanted to paint a little bit of a picture on what we're dealing with in terms of our healthcare cost and quality crisis. The cost of American healthcare is a profound economic problem and an urgent public health problem. Almost half of all Americans have reported having to forego medical care due to the cost. Almost a third have indicated that the high cost of medical care is interfering with their ability to secure basic needs like food and housing. Over 40% of American adults, that's 100 million people, face medical debt. And high and rising healthcare costs are a critical problem for national and state governments. I think you know this all too well. It affects the economic vitality of middle class and working families, crippling the ability of workers to earn a living wage. National health expenditures, which includes both public and private spending on healthcare, have grown from 27 billion in 1960 to nearly 4.5 trillion in 2022. Relative to the size of the economy, that means our health expenditures grew from 5% of GDP in 1960 to 17% in 2022. And it's projected to get much worse, growing to a total of $7.2 trillion or 20% of GDP by 2031. That means a fifth of our economy will be spent on healthcare. This far outpaces what similarly situated countries are spending on healthcare on a per capita basis. The US spent just over $12,500 in 2022, which is $4,000 more per person than any other high-income nation. And the largest proportion of this spending is on hospital care, which accounts for 1/3 of health spending at a whopping $1.4 trillion a year. Since 2015, hospital prices have increased by as much as 31%, growing 4 times faster than workers' paychecks. And high hospital prices are resulting in about $240 billion in waste every year. As the largest category of spending, that means hospital prices are the biggest driver of increasing costs that are impacting people in a variety of direct and indirect ways. It means they're built into premiums, resulting in lost wages. We're seeing high and rising and variable prices across a wide range of healthcare goods and services, including prescription drugs and diagnostic tools. These prices, as we said, are also irrational with no relationship to quality of care. Some of the stats here, paint a little bit of this picture. Average pricing of MRI in the US, just under $1,500, which is 3 times higher than Switzerland, 7 times higher than Australia. That price can vary widely within one single hospital system. And we're seeing privately insured consumers and employers paying an average of 2.5 times what Medicare would pay for the same inpatient and outpatient services. We know Medicare is not always the end-all be-all source of what is irrational or fair payment, but it's the best proxy we have given their ability to negotiate for pricing and to set set reasonable prices. So that's a great proxy to show us that people with private insurance are really suffering because of these variable prices. And for all that spending, the quality is not better. Not even actually more volume of care, but certainly not better quality of care. We're seeing things like 72,000 hospital-acquired infections, high rates of preventable deaths. Despite spending 2 or 3 times more than on healthcare than in other countries, the US has some of the worst health outcomes, including some of the lowest life expectancy and highest infant mortality rates. And this all goes back to, the product of broken financial incentives in our system, within the system that reward building local monopolies and incentivize price gouging instead of rewarding success and promoting health and well-being of the community. I do want to emphasize that when we talk about poor health outcomes, these are not shared proportionately across populations. In fact, poor health outcomes are even worse for people of color who experience higher rates of illness and death across a range of health conditions compared with their white counterparts, which means they're taking the brunt of exorbitant and unjustifiable prices that are largely due to these trends in consolidation that have eliminated competition and allowed monopolistic pricing to flourish. I'm going to hand it over to my colleague, Jane, who's going to really talk through what we see nationally in consolidation, and then we'll jump into a bit of a state picture.
Great. Thank you, Jen. And thank you all for having us today. So I think as Jen just illustrated, our health system is in crisis and consolidation is really playing a dominant role in getting us to where we are. So when we're talking about consolidation in the healthcare space, it can look many different ways. And this is probably a fairly simplistic view, but I'll just talk it through a little bit to make sure we're kind of all on the same page here. So first, we have horizontal integration, which is, involving the acquisition of another company in the same business line. So we often see that with large hospital systems and coming in and buying up smaller hospitals. We see it with insurers merging together. We even see this, on a smaller scale with independent physician practices merging together. And then, of course, it's happening in the pharmaceutical space too. Then we have vertical integration, which is when a company is taking control of another entity kind of in a different sector. So in healthcare, that often looks like a large healthcare system or hospital buying up smaller physician offices. Sometimes it involves providers and insurers merging in a market. We also see this with pharmacy benefit managers and insurers merging, drug manufacturers, wholesale distributors, retail pharmacy outlets also kind of get in the game too. Think CVS buying up Aetna, Amazon buying pharmaceutical startups. It can look many different ways, but this is kind of a good overview of what we're talking about here. So in terms of trends, consolidation is on the rise, and it's broadly taken place without meaningful regulatory oversight or interventions, and it's becoming more acute. So I think you can see some statistics here that I won't read through all of them, but I think we can just show that there are few truly competitive health markets left in our country. And, you know, hospital mergers in particular are happening more frequently, both within and across healthcare markets, and this is leading to higher prices in both cases. According to the American Hospital Association, between 1998 and 2017, there were about 1,500 mergers, and 40% of those happened between 2010 and 2015. So that's to illustrate that it is on the rise and it's becoming a lot more common. I think when it comes to insurers, the insurance market is not nearly as highly concentrated as providers, but there is still a lot of evidence of markets with little competition between insurers. And when we're talking about the four biggest insurance companies, they control over 80% of the market nationwide. With vertical integration, we're seeing a huge increase in the number of hospital-acquired physician practices. Between 2012 and 2018, this number doubled. And today, over half of physicians are now employed in hospital-owned practices. I think when we're thinking about physicians now, being a lot more frequently employed by hospital-owned practices, that trend really was accelerated by COVID-19, and that obviously really exacerbated a lot of the financial vulnerabilities of smaller and independent practices, and primary care was particularly hit hard by that. And many primary care physicians now work in hospital settings. So what does this mean for affordability? So, nowhere is the negative impact of consolidation more evident than the rising cost of hospital stays and services. And as Jen laid out, this is, becoming the negative impact consolidation is really, increasing dramatically. I think we can go to the next slide, Jen. This is the right one. While, over the last decade, hospital spending has gone up and up, and these costs have increased despite having lower hospital utilization. And that's because these prices are going up. Increased consolidation is eliminating competition, allowing these medical monopolies and really large healthcare corporations to form. And there are some stats on this slide that really show that we know what can happen when there are, a large amount of both horizontal and vertical mergers. Long story short, the prices are going up, costs for consumers are going up. And with less competition in markets, these health systems are really able to charge whatever they want to an extent. And there is this lack of competition and oversight. So our colleagues that gave the presentations previously did a really great job, I think, kind of illustrating what the role of private equity is looking like in the state. I'll just briefly give a bit of a national perspective here. It's becoming, private equity is just becoming a bigger and bigger player in all of this. And now vertical and horizontal healthcare consolidation have been occurring for a while now, and long before this kind of more recent growth of private equity involvement. But as the PE trend is growing, I think, again, it's already been illustrated that we're seeing this a lot with staffing firms employing anesthesiologists, emergency department physicians, also owning hospitals outright. We're seeing these further impacts on consumers and patients. Showing right here that around 9% of non-public hospitals are now owned by private equity, and that's an even larger number when we're talking about for-profit hospitals. And we would say that overall it is playing a harmful role in the healthcare system, worsening, as you can see here, quality, affordability, and access. And I think that's because the business model of private equity is really fundamentally at odds with delivering high-quality, patient-centered care. We're looking at a business model that is applying a very short-term and profit-driven kind of lens to all this. And when that's applied to healthcare, the consequences can be really dire for patients. So again, I think now we're going to click down a bit, again, back to the state level, and I'm going to turn to my colleague, Erin, to talk a little bit about what these trends look like and how consumers and patients are being impacted in the state. And then we'll talk solutions and wrap up.
Great. Thank you, Jane, and thank you everyone for having us. So with that national context in mind, let's take a closer look at affordability and accessibility of healthcare in Nevada. So as you all know, Nevadans continue to struggle with accessing the medical care that they need. Over half of all Nevadans report delaying or foregoing the care they need due to the high cost, and the vast majority of which worry about affording healthcare into the future. We can also see that at the same time, on important measures of healthcare quality, Nevadans are not receiving or have access to the high quality care and treatments that they deserve. For instance, too many folks are not receiving appropriate screenings and tests, nor receiving treatment for their health conditions, such as treatment for mental illnesses. So why is this? Well, what we see driving this healthcare affordability and access crisis in Nevada and across the country is really a fundamental misalignment between the business interest of the healthcare sector and the health and financial security of Nevadans and people across the country. Specifically, it is high and irrational healthcare prices, especially hospital prices.
I'm sorry to interject.
No problem.
Recognize that we probably already had discussions on Nevada, so I'm wondering if we can skip to a few slides straight to the policy solutions, if we can talk about that. And I apologize for just going all over the place, but I want to make sure that we're utilizing our time the best that we can.
Absolutely. Jen, would you like to go to slide 18? We can.
And perhaps if we can focus specifically on the state one, that would be helpful.
Absolutely. So I think, wanting to really, before jumping in, really want to recognize that you all have taken such important steps in your roles as state legislators to promote affordable, high-quality healthcare in the state. For instance, the work you've done on improving transparency with your all-payer claims database, strengthening state oversight of healthcare market transactions, reining in anti-competitive practices, et cetera. So just to really recognize the important work that you have done in the past. And in addition, at the same time, based on what I'm sure you're all seeing on the ground, what we're seeing based on the data, that there is also more work to be done here. And so to that end, definitely want to highlight a few key policy opportunities for your consideration. As we've laid out on the slide, a menu of options here that you all as state legislators can consider. But in particular, what we would want to kind of raise for you are four main areas moving forward for you to consider. So the first is to further improve healthcare transparency, urging you to consider codifying the federal hospital price transparency regulations in order to have even more data on healthcare prices across the state, more complete data, and to understand where low and high value care is being delivered and to hold healthcare providers accountable. The second area that we would urge you to consider is to regulate high prices at the provider level, banning unfair hospital facility fees that are increasingly being billed to patients, even when they are seeking care in a doctor's office or a clinic. As we've laid out, this has grown worse and as more and more large hospital systems have been buying up small local doctors' offices, unbeknownst to their patients. The third policy area is to strengthen competition and prevent further consolidation further. And to that end, urging you to consider strengthening the authority that the State Attorney General and or the Department of Health and Human Services has in overseeing healthcare mergers and acquisitions by giving them explicit authority to not only review or be notified of a given healthcare transaction or merger, but also having the authority to approve or legally challenge that merger. In addition to that, also encouraging you all to give one or both of those agencies authority to make conditional approval. So, for instance, if a healthcare transaction or a merger is being proposed, making sure that that provider maybe isn't closing that rural health clinic like a year after that merger goes through or that acquisition goes through. And so the last policy area to highlight for you all is we would urge you to consider building on the important work that you've done in putting in place a cost growth benchmark program in 2021 and strengthening the enforcement mechanisms associated with that. So in addition to using the name and shame approach and calling out the drivers of unsustainable spending in the state, also adding authority so the Patient Protection Commission, for instance, can put in place a performance improvement plan for those particular providers or sources of unsustainable spending. In addition, also considering the authorization of financial penalties for those providers or insurers or whomever are driving unsustainable spending, are not complying and ensuring that they are complying. So we can go to the next slide. And so this slide is just to say that, the policies that we're recommending you consider today, they represent common sense, popular reforms that are increasingly being adopted by states across the country. So all to say, you all are in good company here. You have, broad adoption of these reforms across the country, and importantly, the support from your residents to build on the important work that you've already done and to keep going to ensure that Nevadans have access to the health and healthcare that they deserve.
Great. Thanks, Aaron. And we'll just kind of skip through these last few. We just really wanted to illustrate that there is a growing understanding that the status quo is not sustainable. So not only is there momentum on the state level across the country, including in Nevada, but on the federal level too. And I think that we really hope to see the federal momentum continue along with robust leadership at the state level. I think oftentimes we all know the feds can be a little slower to act, and it's when states are out there showing leadership and progress that Congress and the federal, the administration can be more incentivized and inspired to act. So we just want to close with some polling here. We'll particularly kind of click down on the state stats, really just showing that there is public appetite for action. I think we are, in what can often feel like a particularly partisan political time, but hopefully we've highlighted today, along with our partners, that these issues are really critical to act on. And I think the fact that this meeting is happening today and you're dedicating time to these issues really shows leadership, and it's really critical that these are even being considered. So again, we appreciate all the work that's been done already in the state by you, your colleagues, your advocacy partners at the Culinary Health Fund, and your constituents. So thank you again for having us participate. We have just one last slide here, just highlighting some resources that we're happy to share these links in follow-up. And now we'll turn it back, and we're happy to go through any questions.
Great, and thank you so much for that presentation. So before we go to questions, I think I wanted to set, again, the floor of why we're having this conversation. I think in general, what we've seen over the last few years is perhaps a consolidation in healthcare. There's, as the presentation mentioned, there's examples of horizontal integration and then, of course, vertical integration. There are perhaps some sectors of healthcare where we can easily identify that the insurance company owns the physician that you go to or the provider that you go to, and they also control the pharmacy and all sorts of factors and other companies are involved in the system. I view this as a bipartisan issue because when we have out-of-state entities coming in-state and ruining the contracts or the agreements that we have of our system that's already fragile, then that can become a national security issue. In terms of, and then to that same point, there's also the concern that if there are, as companies are starting to get integrated with one another, the example in vertical integration, what happens in the instance where cybersecurity now enters a conversation and the company that is at risk, right, leads to other companies now being at risk. And we just saw a news article of Nevada physicians falling into this very recently. And so I think there's at least a discussion of what transparency can look like and how this impacts the day-to-day patient, because most patients don't recognize the person that they're receiving a bill is actually controlled by some other entity. And then when that is in the hands of Wall Street, right, his sole interest is just making a profit, and it's not really in terms of what's at stake within our own borders as a state, that itself can become problematic. And so I just want to make sure that we all knew what is happening and why this is relevant now more than ever. And it's not just Nevada looking into it, it's other states as well. And in the presentation, this is also a federal bipartisan priority to look at the role of private equity. So I want to just open it up for any questions that committee members may have for either the folks presenting or anything in particular. Senator Nguyen.
Thank you. Thank you both for that presentation. I know that there's some policy solutions that were included as a part of that presentation that you just went over, and I know that some of them, members at this table here, at least in Las Vegas, have been working really hard to begin that process of enacting some of that. Are there states that have like a gold standard in this transparency, or have like ideal all-payer claims databases that are up and running that they've been able to utilize that information collected from some of these policy recommendations, or would we be on the forefront of that in our state? And I'm not sure
Yeah.
who wants to jump in and answer that.
I'm happy to take a crack at it, and then if my colleagues like to jump in too, I think that's a great question. And I think, first off, I would say I think states such as Massachusetts, Oregon, others that they've been able to stand up these all-payer claims databases to then inform their cost growth target benchmarking work, their ability to target where providers are, really playing a leading role in driving unsustainable spending in their states. And I think we know even Massachusetts, actually both of those states are even in conversations to up the enforcement mechanisms around those providers that are, driving unsustainable spending. So I think I would just highlight those two states in particular. Of course, there's many others who have stood up all-payer claims databases and are using it as part of their oversight of their markets. And, so happy to also follow up with more examples, but those are just a few.
Have you found that between those two states that they have commonality? I mean, we already heard, and I think a lot of us on the committee are aware that I think someone said 80% of the healthcare industry is controlled nationally by 4 or 5 different insurance companies. And so I imagine there would not be too much of a difference between Massachusetts and Oregon. Is there a difference, or have they been able to look at that information in those two states? I guess I'm asking, can we already start working on legislation based on some of the data that's come out of these other states, or would we suspect that it would be completely unique to Nevada, the information we're going to acquire?
This is Maya Holmes. Can I respond to the committee? Maya Holmes, Health Policy Director for the Culinary Health Fund. I don't think there is a state with a gold standard yet, but I think there are a lot of states that are doing a lot of stuff that we can look at as individually as standards and then build upon based on their experiences. And so I think we have states, we have Connecticut, which has done a lot on its scale, and then we have other states like California and Massachusetts, which have done a lot. And then, Oregon and Washington have also done some stuff. I think a foundational thing that all the states have realized is the need for good data. And we have to have good data, especially on ownership and transactions, if we're going to really start addressing this, that the public and the policymakers, you can't study, you can't regulate, you can't do anything if you don't understand what is actually happening in the market. And the slide that our president showed earlier, that's just a snapshot just from what we kind of, see either through direct experience in the market or we've picked up from reports or newspaper articles, because there's not, and the academic researchers who are studying these ownership transactions, it's difficult to get. So states are really pressing that, their attorney generals and their Department of Human Services and that we need to have that understanding to and then build upon that. So it's a critical first step.
And I'm sorry, if I could just follow up one. In current statute, does our attorney general have that authority to go after some of these monopolistic practices, or do they need that authority, or are they choosing not to do it at this point? Or I don't know if you know that answer.
Maya Holmes, for the record. I'm not an expert on what the Attorney General's rights are. My understanding is in general, Attorney Generals do have authority to address, anti-competitive practices and broken markets, because the ideal is that you have competition in a market. I think the Attorney General in previous sessions, they've done some work to improve their tools, but I think it's critical that we look at what the tools that the AG has and whether that can be enhanced. And that's happening in other states, and other states are really looking at those tools that they have to ensure that the Attorney General can do that. Because one of the problems we see with the consolidation that's happening is the federal level, the threshold for reporting is very high. It's like 111 million or something for a transaction to be reportable. But what happens, and there's a lot of smaller transactions that are occurring, and they're not reportable, so they're under the radar. And then, but all of a sudden you realize, oh my gosh, this company's got 30-40% of the market because they've rolled up all these smaller practices. That's what they saw in Texas. That's what they saw in Colorado.
Thank you.
And if I could, Mason Van Houweling, CEO of UMC for the record, and to answer your question, ma'am, on both those questions, I served recently on the Patient Protection Commission for 4 years, and now a new commission is set forth, but that was what that commission was working on, the price transparency and looking at the studies. And is Massachusetts or Washington, clearly those were much more mature programs, but we were really doing a lot of the good work on utilizing kind of their methodology and trying to figure out the formula to look at our state as a study. I'm not sure if that patient protection is going to continue that work, but also kind of back to the core of AB 11. And again, I compliment both committees' work on that. I think that's at the core of it, is looking at these smaller transactions that happen. And again, we've had multiple attorney generals' opinions on that. And again, that was something we were trying to bring clarity. So I hate to look back a couple of years ago, but that's kind of where your questions, we were looking at those both in the Patient Protection Commission, actually that group, which was a very diverse group of payers, patients, pharmaceutical, hospitals, and others. So hopefully they'll continue that work. But I'm sure they would love to get in front of you at some point.
Yeah, no, and I certainly agree. I think that I know there's a few questions in Northern Nevada, so I'll go after this. I think in general, oftentimes, and this is again just my personal perspective, it's easy to see hospital consolidation just because that's usually where the attention focuses. But while we're focusing on that, there's obviously other sectors of healthcare, ophthalmology, dentistry, that is easily going through consolidation. We're not paying attention to it. And I think what people forget is, under the premise that Nevada is already ill-equipped to handle the resources, right? We had the presentation today that we don't have all the residency programs that we need to. We don't have all the specialists that we need to. And so if we only have, say, 3 specialists for allergy or ear, nose, and throat specialists, a company could very easily come here and control a large portion of the market, and there's nothing stopping them. And so I think that there are obviously cases where consolidation could make sense, especially if they're in critical areas and they're about to go bankrupt. But there's also a transparency effort that should exist so that at least the public can have an understanding of what could potentially happen with my practitioner, especially if my practitioner decides after it gets acquired from a private equity company, then say, you know what, I'm not going to accept your insurance anymore, or we're not going to accept Medicaid patients anymore. And that could have a lot of detrimental outcomes in terms of receiving the care that you critically need. So all that for rambling. Senator Titus, I think you have a question?
Yeah, thank you, Mr. Chair. I appreciate that. I have a couple, if I might. First, for the Culinary Health Fund folks, can you describe what you folks are? Because my question revolves around, do culinary union members have to be a member, or does their fees go into your Culinary Health Fund?
Yeah, this is Jesus Vilueta on the Culinary Health Fund on record. Well, all the culinary union workers get health insurance through the Culinary Health Fund. So we basically pay for benefits. So we go out, we manage our own network, and we're building out our own medical centers as well, because there is a lack of practitioners in the area. We partnered with Keck Medical out of USC to provide primary care for our members, but they have the option to go to any physician in the network if they want to.
Right, but technically you're an insurance agent then?
No, we are a Taft-Hartley fund, and we're self-insured, and we pay for their health care benefits.
Right. Are they mandated to, with their fees as a union member, do those mandate, or can they shop around for other insurances? What I'm getting at, are you yourself a monopoly?
No, we're not. I would not say we were a monopoly at all.
Do they have options to go to other insurances? Can they take that instead of be still a member of the union and still go seek contracts with another insurance company?
They can, but it doesn't cost them anything, let's say, and it's a pretty rich package. It's an open PPO package, so they can. There's always the option. Rarely have I seen it happen.
All right, and then just a curiosity. you're a fund. Do you make a profit? And if you make a profit, do you lower the dues of your members? Does it go back to your members?
We always look at the benefits and see where we can improve, but we're a nonprofit organization. We're not looking at an EBITDA of any sorts. We're reinvesting into the fund and back into their benefits.
So they never get reimbursed or lower the
Senator
cost?
Titus, I just want to make sure that this is not a culinary health presentation directly at them. The intent was to talk about consolidation. So I just want to make sure that your questions are in line.
appreciate that.
But I will let you continue.
Thank you. I appreciate that because one of the things that I see as a doc that was in private practice and couldn't afford to stay in private practice anymore because of the rules and the costs is that I had to go work for our hospital corporation. So many times when we change our practice and not in private practice, it's because we can't exist any longer under current structure and regulations. And so when I hear folks present about and are against us consolidating to stay alive, always wonder what the background is. And I really needed some baseline on, are you indeed, calling the kettle black perhaps? And it sounds like you're not, but I'd love to see a little bit more information about the corporate structure of what you run. And so thank you, Mr. Chair, for allowing me a little line of questioning.
You got it. Anyone else with any other questions? Seeing none, we'll go ahead and close this agenda item, and I appreciate the conversation. If we have any further questions, we will go ahead and take them offline. Thank you so much. We will now go on to agenda item 10, which is a presentation from the Nevada Nursing Programs on the impact of SB 375. With us, we have Dr. Natalie Brown, who's Assistant Vice Chancellor for Workforce Development, and then we also have representatives from all of NSHE. So if you can please make your way forward. And please begin when you're ready.
Well, good afternoon, Chair Doñate, Vice Chair, members of the committee. For the record, my name is Natalie Brown, Assistant Vice Chancellor for Workforce Development and Community Colleges for the Nevada System of Higher Education. I thank you all for the opportunity to present an update on SB 375 funding, along with the impact that funding has had across various institutions to date and plans for the next fiscal year. First, I want to brag a little bit about our nursing education programs and highlight the great work occurring in NSHE. Each program is committed to excellence with high retention rates, on-time graduations, and impressive NCLEX pass rates. Through collaborative efforts and ongoing consultation with community agencies, graduates are well prepared to meet the evolving needs of the healthcare sector in Nevada. We thank you again for passing SB 375 this past legislative session to grow capacity in these high-quality nursing education programs to assist in meeting the rising demand for care in Nevada. As you're aware, SB 375 appropriated $10 million each year of the biennium to expand undergraduate and graduate nursing programs within NSHE. After passage of SB 375, business officers within NSHE came together to determine allocations. The fiscal year 24 allocations are outlined here for your review. The allocations were determined based on current enrollment levels of nursing education programs with a funding floor of $500,000 to provide an adequate level of funding to each institution. Nursing education deans and departments created proposals on how they would utilize the allocated amount to maximize program expansion. For allocations, we have started with fiscal year 24 and will soon reconnect with programs and business officers to review allocations for the coming fiscal year, adjusting as needed to maximize outcomes. The chart before you outlines the FY24 authority by institution, total expended year to date, amounts obligated, and total remaining for this fiscal year. Actual funds were received by institutions in September, and recruitment of positions needed for expansion began. A few institutions have been able to hire positions, including nursing faculty and support positions, where others still have open recruitments, which in many cases is a required first step to expanding cohorts. Equipment, such as high-fidelity mannequins, task trainers, simulation equipment, educational services, marketing, and recruitment materials makes up much of the other realized expenses, with plans to hire open positions and purchase needed equipment and supplies between March through June to close out this fiscal year. This slide is looking at new enrollments in nursing programs at each institution. So to give you a high-level overview, fiscal year 23 is our baseline, and we were approximately about 1,000 nurses were entering the different cohorts across our institutions. And projected by FY25, we're approximately around 1,400, 1,500. And for instance, looking at UNR as an example, in FY23, they admitted 72 students per cohort with 2 intakes per year, or 144 newly admitted students. Starting in FY24, they increased their intake from 72 to 96 per intake period. Some institutions will still have summer intakes during this fiscal year, so these numbers are not quite final. And others are projected to increase to the amounts outlined here for FY25 as long as all goes to plan, being able to hire as needed, getting nursing board approval, and any other steps along this process. As much of the expenses relate to program faculty and staff, we provided this information here by institution. You can see where we've hired and where there are planned or currently open recruitments. There have been difficulty filling open positions, owing in some cases to lack of competitiveness in salary placements, as well as hesitation committing to a position with an end date of June 2025. And that I think you've heard from other various areas this morning. The roadmap to continued success, it does vary little by each institution, but overall, the ability to maintain current staffing levels is something you'll see across each of these institutions. Recruiting and developing new nurse educators and support staff, and each institution has provided a brief outline of their unique plans for how they plan to achieve ongoing success of nursing expansion. And a lot of this is, you'll see differences between different types of institutions, different service areas that they serve, as well as just general expansion efforts. So looking forward in recommendations, continuing nurse expansion grant program beyond FY25 would provide the biggest support to our nursing programs. Realizing gains from expansion efforts and increased cohorts will not be immediate. The increases are incremental as we gain expanded cohort sizes and enter new students into those cohorts. It does take a few semesters to graduate them and realize those increased graduation numbers. The entire process will take no less than 2 years. Securing current funding levels to support expansion efforts is needed to ensure continued success and growth in this sector. Considering a state-funded student loan repayment program with an in-state practice requirement for faculty was one idea to entice qualified applicants into nurse educator positions, as well as recruiting and hiring qualified faculty, which remains challenging. But overall, we are extremely grateful to receive the funding and look forward to next opportunity to provide updates. And with that, I conclude my report and welcome any questions. We also have representatives available from each of our NSHE institutions for any specific questions you may have regarding an individual institution. Thank you.
Thank you so much. Committee members, are there any questions for any of the member institutions? We do have them here. I know that this was a priority from our leaders of the legislature during the last session, and so I just wanted to make sure that they provided where they are with the current spending and all the initiatives that they have forward. So any questions down here in Southern Nevada? In Northern Nevada?
Yes, Mr. Chair, thank you. And thank you for the presentation. And it looks like you're doing amazing work and the money's going where we intended it to be. One of the questions I frequently have from is young folks trying to get into the programs. Number one, that pipeline of young folks who want to go into nursing. I started out as a nurse's aide before I got into medical school. I'm fully aware of the journey. But having the scholarships and loan repayment is somewhat difficult. And so one of the things that I was helped with, my county paid my way through medical school, so then I would go back and practice there. And so reimbursement is sometimes a barrier actually, as opposed to support during the education process. Is much of this money going, any of this money going to actually helping pay not just for the school itself, but for leaving expenses and those kind of issues that the students have during this journey?
Thank you for the question. For the record, Natalie Brown. The SB 375 funding is not outlined for direct student support. A lot of this is for faculty, staff, operations, and supplies.
So what I see is that we perhaps need to look at that again and make sure that some of this forward thinking is actually helping support and even the instructing, reimburse them while they're getting this education, because they can't be working when they're doing that. So for me, that would be something that should be a good discussion, and how we can use this money to actually secure these. And then the final question I have is, under recruitment and retention of faculties, on that page, what is it? I don't know, you gave the list of all the ones that you hired. Will open recruitment for 2 simulated education. You hired, so you've been, it looks like, fairly successful in actually hiring, and that would be the key. Is we frequently will authorize funding, but then you can't fill a position. For example, the GME funding earlier today, they are still working for somebody, but it looks like you've been fairly successful in hiring. As a matter of fact, on that page, everybody's been hired, and you're only opening up like a recruitment process. Is that what I'm seeing here?
For the record, Natalie Brown. What you're seeing here is for College of Southern Nevada, for instance, they are going to IFC for approval for authority for the funds in April. And so these are some of their planned openings utilizing the SB 375 funds. For some of the others, I think there's been more success in some of the support positions. We are still having some challenges in hiring faculty. And it looks like I have a few of our representatives, one from Great Basin College, Stacy, as well as Julie Ellsworth, Dean from Truckee Meadows Community College, which I'm sure they want to speak a little bit on that front.
Great.
Stacy Warnert, Dean of Health Science and Human Services at Great Basin College. As fully aware, faculty, hiring qualified faculty is a challenge anywhere. It's even more challenging in rural areas. We have been successful in hiring 1 nursing faculty in our Elko location, but our nursing program is located in Elko, Ely, Winnemucca, and Pahrump. Pahrump is our area where we can grow, an area of greatest need and where we can grow. And we are still seeking 2 nursing faculty still in Pahrump, and those faculty members will be essential in our ability to expand our nursing program there in Pahrump.
And Julie Ellsworth, Dean of Life Science, Allied Health, and Public Safety at TMCC. And we have had great difficulty recruiting and retaining faculty. So during the COVID period, so our core faculty for full-time, and then we have a cadre of part-time, but our core faculty of full-timers was 12 prior to COVID, and that was allowing us to have 40 students accepted per term, so 80 graduates per year if they all went through on time. We lost 10 of those 12 faculty during COVID for going either early retirement or going to better paying jobs in industry. So we had 10 vacancies. We, over the last 4 years, have been able to fill 6 of those 10. We have had 4 ongoing vacancies since COVID. And even with this funding, we offering another vacancy with 2 years of funding is not attractive. We have successfully raised our baseline salaries, but that has to be done across the board. For all of our faculty, this wouldn't be enough money to raise even all of those temporarily. So recruiting and retaining faculty is an ongoing issue to grow our cohorts.
Well, if I might, Mr. Chair, I thank you for that clarification, because I know that we've had difficulty in Yarrington finding for our nursing assistant program, finding a teacher for that. And so when I looked at this page that NCHI put together on recruitment and retention of faculty, and talked about hired nursing director, hired 5 nursing faculty, hired 6 at UNLV, and hired 5 nursing. I'm just wondering, is that true? You were able to hire all those folks? Because what I'm hearing actually is that there's openings, but you're not really able to fill what you could.
Julie Ellsworth, TMCC. At TMCC, correct, we have ongoing postings. We do, we get a few applicants. We interview those applicants. Oftentimes, we're not offering enough salary for them to take a offered position. So for us, we have been able to hire with these funds a nursing concierge, which is a support staff person, but we've not been able to hire any additional faculty.
So if I might, Mr. Chair, I'd like to, and I'm sure committee members would like to see when it talks about the recruitment and retention of faculty, you pointed out your success, and I appreciate that, but I'd like to see the voids. I mean, what's the real picture here? Yeah, you hired that person, but you really need 20. And that paints a different picture than this sheet that I'm looking at, which looks, wow, I was impressed, and which is why I asked these questions. And so it would be nice to know. And then the next, are there barriers that you see that we could help with that? I mean, everybody says salary. I get that. I know our traveling nurses, we have people that live in our communities that become traveler nurses because they make more money. I mean, I realize money, but are there other issues? Is there an issue with getting them licensed? Is there a process there? Do you see anything that we could do to assist you?
Senator Titus, this is Imelda Reyes with UNLV for the record. I love that question in terms of addressing barriers, because I think there's one issue that would address the pipeline and the barriers. So one of those slides that you saw showed the enrollment growth. One of the issues that we find here within the state of Nevada is that I have the capability, I was able to hire the faculty that I needed, and I have a projected growth that I would love to grow to 408 students per year. But one of the issues that we face, and I know other facility or other schools face as well, is that I don't have the clinical capacity. So I have to rely on clinical partners in order to place my students. So currently I'm at 312 students, and it makes it difficult because within the state, we don't necessarily measure or regulate how many schools are in this area. So that is definitely a barrier. And then in terms of the pipeline issue, here, and again, I can speak to UNLV, we have 900 students that enter UNLV wanting to be pre-nursing students. And again, I'm able to meet that need of 312 to 400 per year. But again, it comes back to the issue of being able to clinically place them throughout their education. So it's not so much that, we're very economical in terms of the cost of their education, but I don't always have a placement for them, which is a limiting factor.
Great, thank you. We heard earlier from the deans about the community partners, and we would certainly want to have community partners in our nursing programs too.
Right. This is Cameron Duncan. I'm the interim dean for the Orvis School of Nursing at UNR. And I just want to echo really what Dean Reyes said. It's not just our nursing students, though, who are having challenging challenges with clinical placement and being able to get into the hospital and actually complete the required hours of training that they need. It's also our graduate students who are nurse practitioners training in many different specialties that are having a really hard time with the competition of private schools and those students coming in and trying to get their rotation. Unfortunately, within the state system, we don't have a way to compensate these preceptors or these clinicians who are taking our students and training them in their clinical sites. If we were to have some way to compensate them or to support them a little bit more, I think it would help with the process of getting these students into these sites. Unfortunately, some of the private schools are able to compensate them, but as a state agency, we're not. I am familiar with some other states who offer, tax credits to nurses or nurse practitioners who are training. That's not an opportunity for us here, but if we can find some type of solution like that, it'll really support us growing our nurse practitioner programs and really filling those primary care and specialty care shortages we were talking about earlier.
Thank
Dean
you.
Duncan, how much do you, sorry, Senator Tice. Did you have one more thing?
Just a comment, and thank you for that, because I taught many a med student, many a family practice resident, and also I taught many a nurse practitioner student, and I've never been compensated for it, but I recognize that's a real barrier, so thank you for bringing that up. Thank you, Mr. Chair.
Thank you, Senator Titus. You brought up excellent points. Dean Duncan, do you happen to have an idea of how much funding you would need to help incentivize preceptors, or what the capacity of need is?
Yeah,
And I know you can speak only to your institution, and perhaps UNLV and other institutions could speak on as well.
Right. So that's a very difficult question to answer because it really depends on the region where these students are training. At our school, we have students who are in Reno training, we have them in rural areas training, and we have students who are out of state training. And all of those challenges apply in all of those locations. But for instance, California, the amount that we might have to pay a preceptor is going to be much different than what we might have to pay here in Nevada. And probably the same thing is true in Northern Nevada versus Southern Nevada. Are you familiar with some other
So
rates?
Imelda Reyes for the record. Some of the, there are lots of different models, and I think one of the things I just want to highlight is that we in nursing, unlike graduate medical education, are not funded. So our students, for instance, in some cases are paying themselves for their clinical rotation. So they're in clinic settings and then paying for that. And so on average, students pay, if they're paying on their own, $500 to $1,000 per rotation. So other states, for instance, I recently came from the state of Georgia. The tax credit that they had in place there, for every 180 hours that they precepted a student, they got $1,000, for instance. And so that basically is like a clinical rotation for a semester. And, you know, it makes it difficult when we don't necessarily have that mechanism that we can use here within the state. But I did cost out, like if I were, you know, again, to do something like this, compared to graduate medical education, it isn't quite as expensive, but, you know, even having any, you know, any form of, you know, I have 30 students in family, 30 students in psych mental health, for instance, that are providing, again, that really essential service. But I'm only able to accept 30 students in each cohort because I, again, don't have a clinical placement for them. So again, from that perspective, it's about $500 to $1,000 per clinical rotation. I am more than happy to get, you know, what it would cost to be able to provide these clinical rotations, but that gives you kind of a roundabout figure.
Yeah, and if I can add, just to put that into context, each of our nurse practitioner students, we have about 200 at UNR. They go anywhere between 3 and 5 semesters of clinical rotation. So that's at the most about $5,000 per student.
Thank you. In terms of continuing education, have you seen other, I mean, I asked this for physicians earlier. Is that something of interest also for nurses, or have we seen other states apply some of the continuing education credits, like mentorship opportunities, to subsidize or to be a part of that conversation?
Yes, so our certification boards do offer like credit for taking a student, but it generally is not enough of an incentive for them to take the student when, like here, you know, within this southern region of Nevada, I have other entities that are paying. So like my family nurse practitioner students, for instance, it's really difficult to get them a pediatric rotation because every other school is paying other than me.
Yeah, I think that makes perfect sense. You know what I know we have to move on to our next agenda item, and I apologize for not being as robust, but perhaps it might be an interest to bring you back a second time and we can follow up with you. What I would like to see in terms of, now that we have, so I think obviously there are our healthcare partners were interested in also seeing this because they are on the receiving end once the nursing students graduate and so forth. And I'm glad that we've at least have made some segments of applying the funding and I know it's often difficult to try to figure out, okay, now we have the pot of funding, how do we make sure that we're addressing the needs? What I don't see in this presentation, and perhaps it's more institutional based, and I would assume you already have these, is I would like to see, this is where we're at, this is what the funding received, right? You have this on your slide, but this is like the actual need that we haven't even reached yet. And so the easy example would be maybe you have 10 faculty, but in realistic, based on the number of students and applications that you're receiving, you need at least 20 faculty, and you have 10 preceptors, but you need at least 30. We would like to see what those gaps are and what it would take for funding for each of the institutions. And I think you already know those numbers, but you have to start thinking through them so that we can take in consideration, okay, we gave you this amount of funding last time. Now we set the parameters of where you need to go within the next few years. And so if you meet those goals, then we'll increase the funding for you so that you have a level of accountability that goes through. And I would imagine like I said, you're already doing the work, but I think if we have like a strategic plan, and maybe that's something that NC can help coordinate over the long term, and perhaps they already are, but I think that can help us as legislators to realize the monetary value of, okay, we're giving you funds, and now let's go do something, right? So I would at least appreciate receiving those data points at least until before we go up to the legislative session, and that could also go into BDR consideration as well. I don't have any other questions or comments unless if anyone else does.
Sorry, Mr. Chair. One more,
Senator Titus.
if I might. I just also want maybe an update on the nurse apprentice program, because it's something we did right. And during COVID especially, we were able to get these nursing students that needed to go out and do rotations and actually get reimbursed through the nursing apprentice program. And so perhaps in the future, if it's okay with you, Mr. Chair, an update on that and perhaps the funding needed to continue that program, because I think it's something we got right. So thank you. Thank you, Mr. Chair.
Thank you. And just as a final point, I think the thing that our partners in healthcare are always more worried about is making sure that, and this came up obviously for debate last session in terms of increasing the class size to faculty ratio. I think we need to just, again, be mindful of like, what are the gaps that we need over time and how are we closing those gaps and are we being competitive to other states? So we definitely need to start, if the issue is being competitive towards the private programs, obviously we have an obligation to the public education system to make sure that you have the resources you need. And so let's have that discussion and then let's set some metrics of accountability. Like I said, so if you meet them, then you can be rewarded for it. But I think we're at a good place so far, at least from what I see. So I appreciate all the work that you guys have done. And I don't think there's any other further questions. So we'll go ahead and close out this agenda item. We are going to move on to, we have two more agenda items to complete. So we have agenda item 11, which is the overview of emergency medical services, workforce challenges, licensing issues, and future considerations. And then we have our last agenda item 12, which is submitted policy recommendations. We only have one, and hopefully that one should go very quickly. For our EMS presenters, I know your presentation is pretty robust. But perhaps we can, Ms. Sullivan, if we want to skip through and just talk about, I think in some of your issues, I think it's like slide, I don't know, it's like slide, hold on, I'm like, it talks about funding and challenges. Maybe we should start at slide number 10. That could be helpful. So we just go straight into the problems, if we can.
Good afternoon. My name is Cody Finney, and I serve as the administrator of the Division of Public and Behavioral Health. I am here today with Bobby Sullivan. We will be as quick as possible. I will say on that nurse apprentice program, if I might digress for one piece, we were the pass-through agency for that, so happy to provide any information and help our partners at the Board of Nursing. All right, I'm going to run the slides. I'm going to let Bobby talk, and then we'll be happy to answer your questions. Is that all right?
Please proceed.
Good afternoon, Senator Donate. Thank you, Chairman, for this opportunity to provide you an overview of the EMS program. Beginning with slide 10, our funding challenges that we have. This is our current revenue source and allowable uses for that funding. Our general fund operating is $1,059,424. We also have an emergency medical services for children's grant, which aids in purchase and training for pediatric-related emergencies. Part of the licensing fees that we collect through our applications is used to offset the cost of our tracking system that's used to track education opportunities of the volunteers. Certification fees that we collect are turned back to smaller departments to help support training opportunities. We are in the last year of a Helmsley private grant, which was nearly $7 million to purchase automatic external defibrillators for all of the law enforcement agencies throughout the state of Nevada. That's at $1,722,000, and we are ending that project at the end of October. And then the final line you see there is treasurer's interest distribution. Our workforce challenges, not unlike anybody else, we currently have 4 positions filled. We have 4 that are vacant. One position that we had was a recent retirement of someone who had 20 years within our office, so we lost that institutional knowledge. EMS staff, we do not have a data management person, so staff have had to learn how to make changes to our software data system that affects anything that is within Nevada. Because this is a national program, anything that reflects our regulations we're able to do internally. Some of the workforce challenges briefly. Staff are required to maintain certification and licensure as other professional medical practitioners, including continuing education and verification of skills. Currently, staff have no opportunity for outside employment. It is considered a conflict of interest. In the past 2 years, the candidates who've applied and been selected have declined the job offer due to the wages offered, even with accelerated salary. We currently have no opportunity for growth within the office because of competition from outside agencies, and we also have a large burnout. Some of the past licensing issues that were brought forward in the last session was the delay in processing applications. We currently have a database of active providers of over 4,000 providers. We went to an online license management system in 2019, which significantly reduced the turnaround time for our applications. By the time we go through the process of the applicant submitting that application, if it's an initial application, that's roughly 15 days. It does increase over what we consider our renewal cycle, but at this point we went from months to roughly 2 weeks. One of the other concerns that was voiced about those applications was the expiration date. Under our regulations, certifications cannot be issued for more than 24 months. Currently, we are in the process of changing expiration dates to coincide with the date of birth of the applicant. We're going away from March 31st, which was creating a large influx of applications between January 1 and March 31. With support of our advisory committee, we moved that to date of birth, not only to help streamline the process, less of a glut of applications at one time, but also to help with the providers, making it easier for them to remember when to renew their certifications. One of the other things we were able to accomplish through assistance and guidance from our Deputy Attorney General, we had held applications pending background results. We were informed that we could go straight to issue, and if there was an issue with the background results, we would go towards revocation at that point. Future considerations that we've come across in the last session, there was a voiced concern about having regional areas. Prior administration had directed staff at that time to step away from regionalizations in that direct contact, forcing to just reach out to whoever you could get to answer the telephone. And we are going to go back to regionalization simply to provide that one-on-one contact with an established person so that there's less time explaining the issues on your end. Somebody already knows your area. I got mine turned around.
So while Bobby's getting her information straight, Cody Finney, for the record, I just want to point out that the EMS program is regulated statewide by the Division of Public and Behavioral Health through Bobby's bureau, but in Southern Nevada, the Southern Nevada Health District has that authority within that area. So there are the two authorities across the state. When I say statewide, it's everything but Southern Nevada. We have, as some of the discussion has been today, they have gone to, rather than having all the applications for renewals come in at one time, to spacing it out over the year. and also doing the issue, or not waiting for the background checks and issuing the license, and then going to revocation if there is a problem. Bobby, please continue.
Bobby Sullivan, for the record. I did want to expand on the oversight. Ms. Feeney is correct in that Southern Nevada Health District addresses the credentialing as a primary agency for the Southern Nevada Health District. This office has some level of oversight over all of the counties. Our office issues the permit numbers that coincide with our data collection system, so we have that oversight. We collect patient care reports on a redacted system into the central repository that we send to the National Emergency Medical Information System for data collection that is sent to National Highway Transportation Safety Administration to improve patient outcome in pre-hospital settings. So there is some of that collaborative effort between our office and the Southern Nevada Health District. A couple of the things that we brought, Nevada joined the EMS replica October of last year. We are fully implemented. There's still a little bit of delay on the Southern Nevada Health District implementation, and we expect them to be on board at any time. We did notice immediately that this has made a much smoother movement of EMS personnel between the compact states. And what the commission, and I as a member of that commission for the compact, we're working on currently is to identify the states that do not require background checks, and also what does it look like from the time that you enter into that other state, do you have to get state credentialed? Currently under the compact, you can come in, and as long as you're working from a compact state to an agency, that transition is there. But where is that loophole closed so that you have credentials within Nevada? We're working very closely with the compact, and they have been extremely helpful in that process. On page 17, slide 17, back in 2009, the National Highway Traffic Safety Administration was in and did a statewide assessment of EMS. And you'll see some of those direct quotations from that report in 2009. And unfortunately, the week that everything closed to COVID, we were supposed to have a reevaluation. We are currently looking for the funding in order to support another evaluation statewide. So that is on our list. Slide 18, you'll see that there is just an overview from the National Association of State EMS Officials showing most of the organizations of EMS offices around the state. We have a very active and supportive EMS advisory committee. Slide 20. Some of the implementations that we have taken on based on guidance from them, we updated the trauma report guidelines that were in our Nevada Administrative Code 450B. We removed the requirement that a student must be an advanced EMT in order to enter into a paramedic program of training. We supported updates of the pediatric skill verification that all of the providers have to submit when they renew their credentials. And as I explained earlier, we changed the expiration date from March 31st to the date of birth. We recently, based on recommendations from the board, created 2 subcommittees that have both met and are very energetic. One is to review the fees that are charged. Currently, an initial credentialing for a provider is $54. That is certification of $24 and $30 for the ambulance attendant license. They're looking at those fees. They're looking at other fee opportunities and also doing a comparison of other similar states. There are some states that do not charge their providers. All of the fees for that comes directly out of general fund. The other committee is formed to help create a statewide set of protocols. The last issued statewide set of protocols was 2003. So the larger organizations are helping to build that foundation of statewide protocols so that we can bring agencies more on board of similar practices. And with that, I'm happy to take any questions.
Great, thank you so much. And I apologize, of course, skipping a few slides, and I would encourage my committee members, if you haven't interacted with our state EMS office or the folks in DPPH, to meet with them privately. I think they have a robust information of things that they do behind the scenes. And as Ms. Sullivan mentioned, it's kind of interesting because Southern Nevada often operates a little bit differently than the rest of the state, but I think that's kind of what we're here to talk about, the gaps and trying to perhaps update or streamline what we're seeing statewide. Are there any questions here in Southern Nevada? Assemblywoman Brownway?
Thank you, Chair. Thank you for that great report. I just have one relative to the National Highway Traffic Safety Administration recommendation. You noted on your slide 17 that the recommendation is for a new updated assessment. It looks like our last one was done in 2009. Are you currently working with anyone in order to put that in motion? Is it perhaps federally funded with some of the relief dollars that we have in this state? Is there any way to get that moving?
Bobby Sullivan for the record, and thank you for the question. We are looking at multiple opportunities to fund this evaluation. We are working with our direct partner at NHTSA, and we're hoping to come to a conclusion on that and secure those funds probably by the end of the year.
Thank you. Just clarifying, do you have an estimated cost for what that study, how much does it cost?
Roughly $75,000.
Thank you so much for that.
Thank you so much. And just as a follow-up of a comment, I had the fortunate opportunity to meet with a lot of our statewide EMS folks all throughout the state, both Northern Nevada, Southern Nevada, and rural Nevada. And I think there's at least a discussion that perhaps we need to provide a more level of support for Ms. Sullivan and your team in elevating the positions that we have. I know that other states have a model of having a state EMS office under HHS, and I think we had this conversation last time, and we're trying to figure out how can we provide the actual resources so that we can process licenses faster and work in different jurisdictions. And obviously you mentioned the approach of regionalization, which I think we definitely have to find a model that works. And so it'd be interesting to review. I know you submitted the exhibit of things that we should have done in 2009, but we still haven't enacted yet. And so hopefully within the near term, we can put that together in the BDR. But I don't know if anyone in Northern Nevada has any questions, Senator Titus or Assemblyman Gray. Seeing none. Okay. We will, Dr. O, did you have any questions or are we good? No questions. All right. I'll go ahead and close this agenda item. We will circle back when it comes to reviewing the BDRs, but I think, as I mentioned, I would encourage our committee members to read the report just because there are a lot of things that our state needs to do. We just haven't had the chance to do so yet. And so, but I appreciate, of course, the folks from DPBH for being here and, of course, for all that you do for our state. We'll go ahead and move on to the last agenda item number 12, submitted policy recommendations to be reviewed by the Joint Standing Committee on Health and Human Services. So now that we have approached the end of the meeting, the structure that I want to have for each of the meetings moving on throughout the interim is during the first one, we laid out that if you are able to submit on the survey a list of policy considerations and NRS changes, then you could be added on to the agenda item. So far, we've only received that from one group, and so I would like to go ahead and invite the Biomarker Coalition to proceed forward. And then also, we have a few folks that are ready to present online. So if you can just give a broad overview of the policy you're looking to have the committee sponsor, and then we can go on to any questions. And I believe Mr. Hardy is online from the Michael J. Fox Foundation.
Yes, I am here, Chair. Thank you so much for the opportunity. Chair Donate, Vice Chair Ornlicker, and members of the committee, my name is Zach Hardy, and I am a State Government Relations Officer for the Michael J. Fox Foundation for Parkinson's Research. And I thank you for the opportunity to testify before the committee on policy recommendations related to coverage for biomarker testing. Founded in 2000, the Michael J. Fox Foundation for Parkinson's Research has been singularly dedicated to finding a cure for Parkinson's disease through an aggressively funded research agenda and to ensuring the development of improved therapies for those living with Parkinson's today. To date, the foundation has funded nearly $2 billion in research programs worldwide. Assembly Bill number 155, which passed the legislature last year, requires health insurance policies to include coverage for biomarker testing as it relates to the diagnosis and treatment of cancer. Biomarker testing is a crucial step in accessing precision medicine, including targeted therapies that can lead to improved survivorship and better quality of life for patients. While most current applications for biomarker testing are in oncology, there is research underway to benefit patients in other areas, including neurological conditions such as Parkinson's disease. For example, this past April, the Foundation announced that through our ongoing work of our landmark clinical study, the Parkinson's Progression Markers Initiative, also known as PPMI, a new biomarker was identified for Parkinson's disease. This breakthrough was published in the scientific journal, The Lancet Neurology, and opens a new chapter for research, with the promise of a future where every person living with Parkinson's can expect improved care and treatments, and newly diagnosed individuals may never advance to full-blown symptoms. The Foundation recognizes the importance of biomarker testing and how it will soon broadly benefit our community. There are estimated to be more than 1 million Americans currently living with Parkinson's disease, with about 90,000 more diagnosed each year. According to the Centers for Disease Control and Prevention, Parkinson's disease is the second most common and the fastest growing neurological disorder worldwide. In Nevada, there are an estimated 10,000 people currently living with Parkinson's, with direct and indirect costs to care for these individuals estimated to be at $484 million annually. We believe these statistics on both prevalence and economic burden to be an undercount. It is crucial that non-oncology applications be included in the state requirement for insurers to provide coverage for biomarker testing. In the last 2 years, over a dozen states have taken legislative action that requires insurers to cover biomarker testing, while including language that makes this requirement disease agnostic. Biomarker testing has the potential to revolutionize the way that people are diagnosed with Parkinson's and how people who are living with the disease are treated. As the Foundation's own recent biomarker breakthrough demonstrates, advancements can happen at any time, and it is important that patients have access to biomarker testing as an important tool in their healthcare as soon as new tests become available. So on behalf of the Foundation and the community that we support, I thank the committee for the time and the chance to discuss this important topic, and I'm happy to answer any questions.
Thank you so much, Mr. Hardy. And just to clarify, you don't have any other presenters, it's just you on behalf of the bill that you said, the bill proposal,
yes,
correct?
I do. I think it is just me. We have worked closely with the American Cancer Society as well. And as I stated in my testimony, the bill, Assembly Bill 155 that passed last year, does focus on oncology and cancer patients, while we believe there are many other areas that can benefit from biomarker testing and insurance coverage of biomarker testing.
Thank you so much. So committee members, again, so as community members send us policy recommendations, if they meet the requirements that we're asking them, then that would be the time to start reviewing it. We can put this for consideration in a BDR in a later date, but this would be the time that you can gauge and see if this makes sense, provide feedback, etc. I'm going to go ahead and just start with just my anecdote, and then I can have let me start first with a question. In the bill proposal that was submitted, one of the striking things that I saw was you are removing and striking the language of medically necessary. Why would you do that? What's the rationale behind that?
So the preferred language when it comes to discussing when biomarker testing should be covered by health insurance companies is medically appropriate. It may sound incredibly close to medically necessary, but because of the ever-changing research and development of these biomarker tests, there are different ways that these tests make it to market. Not all of them, for example, go through an FDA approval process or an FDA clearing process, and there are certain instances where that can be used against a biomarker test that while it may be beneficial to a patient or to a community, it may not be cleared because it doesn't follow the dynamics of a medically necessary definition, whereas medically appropriate is deemed by a doctor and then can move forward to have a patient have access to a test that could still reveal information related to, specifics about the disease that they may have, whether it be cancer, whether it be Parkinson's disease, ALS, other neurological disorders, and then can unlock more to know between the patient and the doctor about how they go about their treatment, what specific treatment they may need. It may allow the patient to not have to go through certain treatments that may not be the best for their specific type of cancer or the specific disease that they may have. So that is the difference between those two definitions. We've used medically appropriate in other state bills. So that is one of the reasons that there is the difference between those two terms, and why we use medically appropriate whenever we can in legislation across the country.
Thank you. And how many states have passed this expansion? I know that we did the biomarker bill for cancer, and now you're proposing to expand that to other diseases. So how many states have passed that? And I'm assuming it's, based on my own research, it's been only recently. So how many states are we at now?
So we're over a dozen states now. I believe we're at 13 total. And yes, you are correct to note that this has been within the last 2 years that this has been a push that we've seen in state legislatures. But there have been over a dozen, and I want to say 13, but I can clarify that and get that to you and your staff, that have gone ahead with this legislation and have also included language that makes it disease agnostic. So it is not just for cancer and oncology.
And the biomarkers that you're looking to be covered, are they FDA cleared or FDA approved?
So with Parkinson's, there's several that have already been developed and are at different stages of whether it be approval through the FDA. For instance, the one that I mentioned through my testimony that came through our Parkinson's Progressive Marker Initiative, that was just discovered last year. There is a process that has to go on to make that test commercially available and more widely available. So for that test in particular, it still may be another year or two until it is more widely available. But the purpose of having these bills cover areas like Parkinson's now is that so when more tests come online, it isn't the case that we have to return to a legislature and say, can we move outside of the oncology field and have other, whether it's neurological conditions or other spaces in healthcare, covered by the same rules that now are covered in Nevada for oncology.
Thank you so much. And I'm just going to make a quick comment, and I'll let other committee members go. I know Assemblyman Gray has a comment/question. Here's my interpretation of what biomarkers is, and I wanted to have this discussion in this dialogue because I think the description of biomarker is magnitude in itself, and there is quite of a difference between FDA cleared and an FDA approved. And I think that with biomarkers, I know that as I mentioned, there's been an initiative in states all throughout the country, and this is a recent initiative. What I expressed my hesitation last time when we had this biomarker bill was that there are obviously influences that could occur when you mandate things by law. And there's always the discussion of coverage and also payment to ensure that, after all, if we do mandate things by law, that someone has to pick up the bill at some point. I think that's very clear when we talk about just in anything with dealing with treatment. What my main concern is with any biomarker expansion is that if I was an owner of a biomarker company, and again, biomarker is a vast term that has been changing over time. If I was the owner of a biomarker company and Nevada just passed a law that mandated biomarker coverage for a disease, et cetera, as we just did, the first thing that I would do as that owner of the company would be send and hire as many representatives that I could to talk to all the physicians in the state. I would work to ensure that every physician knew that was the priority. And then, there's nothing in law stopping them from receiving gifts or transactions or trips and doing so and learning about this product. And then I would send a notification to the insurance company saying, you have to mandate this by law. And then if the cost of the biomarker was $500 before, I would obviously increase that because there's nothing stopping me from doing so. And so I think these are all the considerations of when we start to mandate things by law. In certain instances, there could be unintended consequences. And I don't want this to be a position of patients feeling like it's a false sense of hope when the science may not always be there, right? If there are technologies that are coming into the market, we obviously should do our best to help engage our patients to receive the care that they need, but it might not be successful. And I think that sometimes we have to just be careful when we do expansions because there could be unintended consequences that it could exist, such as the encounter that I illustrated. But maybe there are other comments from other committee members on this policy expansion. We'll go to Assemblyman Gray.
Thanks, Senator Dunyadi. Thank you for bringing this back. I actually really like it. I'm not a big fan of mandating anything, but you hit the nail on the head when you said that it will help target treatment. And I think if we are able to better target treatment, we reduce the shotgun approach where you're trying different treatments, putting the patient through, I'll just say it, putting them through hell, going from one course to another course. I mean, if you can narrow it down a whole lot easier and have a better idea of what you're actually trying to attack, I think you're, and I think it's already been proven in a lot of cases, there's better health outcomes. And there may be a huge potential here to save a lot of money going forward. But I think this is definitely worth the committee's time to look more into and consider. So thank you.
Thank you, Assemblyman. Appreciate that.
Let's go to Assemblyman Bromley, and then we'll go to Dr. Ornlicker after.
Thank you, Chair. Thank you. I just really have a clarifying question. First, a moment of personal privilege, if you don't mind. The reason that I am here today as a member of the Assembly is because of my personal mentor, and he is a full-time caregiver for his wife of 45 years who has Parkinson's and has gone through many trial treatments and lots of special insurance considerations, right? And so really important that we have access to good quality medical data. I'm curious to know if you can further put on the record, what are some of the other conditions or diagnoses that would be relevant to this type of biomarker testing, right? You talked a little bit about Parkinson's and ALS. Are there others? And what data is turning out as to the efficacy of this treatment and the positive outcomes? Is there anything to support that position?
Sure. Thank you for the question, Zach Hardy, for the record. So I do represent the Michael J. Fox Foundation for Parkinson's Research. So from where I sit, I am able to speak about, the Parkinson's community, their experience, particularly with their path to diagnosis. I will note that with Parkinson's and so many other neurological conditions, whether it be MS, whether it be ALS, that journey to get to a final diagnosis can sometimes take years. And there isn't necessarily, certainly for Parkinson's, one specific test that leads you to that diagnosis. So when we look at biomarkers and the idea of biomarker testing as it pertains to Parkinson's disease, that's where we see so much potential. Because if you're able to, for instance, the biomarker that I spoke about in my testimony, I myself am not a researcher, but in discussing biomarker testing all across the country, I've learned a lot about, the tool and where it can be used. So for the tool in particular that I was talking about in my testimony, it's an alpha-synuclein, which is the Parkinson's protein. And what it's able to do, and through our initial studies, it showed that 93% of people with Parkinson's who participated were proven to have an abnormal alpha-synuclein, which means 93% of people had that biomarker that indicated that Parkinson's, either, whether they had not been identified of being diagnosed with Parkinson's just yet, but could be later on, or they did have Parkinson's disease and it accurately identified through that alpha-synuclein abnormality that they did have the disease. So that's some specific data just on that one biomarker test that I was referring to that came from our long-term clinical study. But yes, there are plenty of neurological disorders that are in a similar space as Parkinson's, where we have seen that biomarker testing has been such a game changer for the oncology space, has really led to a lot of patients and their medical professionals that they work with being able to retool what their treatment plan looks like based on the results of biomarker testing. So what our goal is that to have biomarker tests for Parkinson's disease continue to evolve and through continued research, and even so with the biomarker that I specifically mentioned, there's more work to be done in that space. But there are other neurological conditions, including Parkinson's and others, that do have biomarkers currently available that are also benefiting from those state laws across the country that have expanded beyond oncology, that do have insurers now required to cover these biomarker tests, because they really can be used when people, get that devastating diagnosis and are sitting there with their doctors. They can use biomarker testing to really drill down and save time, save costs on treatments, to say this is the correct path that we should go down in terms of how we're going to tackle, whether it be your cancer diagnosis, your Parkinson's disease, or other neurological conditions. But in a short summary, yes, there are certainly other areas that benefit from biomarkers, including Parkinson's disease. But there are certainly other, coalitions, other spaces that work alongside this issue of advocating for broad expansion of access to biomarker testing. I'd be happy to talk with those groups to get you in your office some additional information. But yes, I'm here to represent the Parkinson's community, but it is certainly fair to say that there are many other disease states that are able to benefit from biomarker testing today, with additional research in the future to expand that even further.
Thank you. And just one quick follow-up. The way that this NRS is currently written, it does not currently apply to Parkinson's. It is specific to cancer. Is that correct?
That is correct.
Thank you.
Thank you so much, Dr. Ornlicker.
Thank you, Chair, and thank you for bringing this important issue to our attention. As you point out, the Parkinson's biomarker is new. So I'm curious, as Assemblywoman Brown May pointed out, there are other, and you've discussed other conditions, and we have a long track record with Huntington disease testing. So do you know anything about the track record of insurers in covering Huntington disease testing? To what extent has that been a problem?
Thank you, Assembly Member, for the question. Zach Hardy, for the record. I do not actually have information on that specifically in front of me. Again, happy to take that back, get back to you in your office with some more background and history on that. But I will say in general, this idea of not to speak to the history of a biomarker specifically there, but in terms of this idea of coverage and bringing it into the conversation of how patients can access biomarker testing, to my earlier point, that this has been a more broad conversation over the last several years in legislatures across the country, because there has been such a groundswell of seeing what biomarker testing has done in the oncology space and trying to replicate that for other, neurological conditions and other disease states, across the spectrum. So certainly it's important to follow the data, follow the science, and make sure that these tests are ready to provide reliable results. But as that happens, that coverage requirement is really what patients, certainly in the Parkinson's community, but I would assume elsewhere, are looking to have, because as I said, when you are faced with these kind of developments and diagnoses and as a patient, whatever you can do to help guide that decision of what to do next with your physicians is what's most important. So specific to your question, I can certainly take a look at that and try to get some more information on the history there. But I would say largely, this has been, for many different conditions and disease states, this has been a much more recent development of trying to have a more broad conversation about what should be covered and, try to make it as disease agnostic as possible so that the most people can benefit from this kind of testing.
Thank you.
Thank you so much, Senator Nguyen.
Thank you. And I appreciate you tackling all of our questions. Obviously, you are the person that's present here and may not have all the answers. So with that being said, I truly appreciate you being a voice for a greater community than just the one that you represent here today. But with that, we're talking about these biomarker testing, and I love the idea that we're able to target using science and this technology to potentially save lives or target treatment in a more evidence-based scientific way. But on the flip side, I know that we use the term biomarker testing kind of generally to include lots of different types of testing. Is there, to your knowledge, do you know if there's different efficacy rates and determining, are there certain diseases that these biomarkers have been more effective? I mean, obviously, I appreciate the fact that we passed this bill to study this, and I know they are going through the process of looking to see what the actual cost savings might be for this, so we have those concrete numbers. But do you know if there's the same kind of effectiveness of these tests throughout, or if there are certain diseases that these tests are more accurate at determining treatment?
Thank
And
you
you may
for the
not know that
question.
information, but
Thank you for the question, and Zach Hardy again for the record. I may not be able to speak, to the full totality and the full history there of all biomarker tests for different disease states. But what I can say is, from where I sit in terms of the Parkinson's community, in terms of coalitions looking at this issue and saying, patients from across the board and across the spectrum of different disease states. And how we can benefit from biomarker testing is, yes, again, not to give too many specifics because I don't have that information in front of me, but generally the space of oncology and cancer treatment has been by far the space that has benefited the most from biomarker testing. There are other certain autoimmune diseases as well that have benefited from biomarker testing in recent years. But again, the expansion and the research that is underway in other areas, including Parkinson's, is what is really spurring this moment to say, where can this fit in terms of a patient's healthcare plan and just what their treatment is going to look like. So thankfully, and luckily, that research is underway across the board. And no, I wish I could speak to, a whole host of different areas on this topic. But what I know in terms of the Parkinson's space, there have been certain biomarkers identified in the past. There was a great breakthrough last year with the Parkinson's Progressive Marker Initiative. And the biomarker identified there that just shows the promise of this technology and of this science. And, I wish I was a researcher so that I could speak more eloquently to the very, very specific nature of these tests. But, what they really can do, the doors that they can open up in terms of how to shape treatment, how to save costs related to treatment, to not have to go down the rabbit hole of attempting different ways of tackling whether it be cancer or any other, disease that people are afflicted with. That's really what, the conversation is all about. So again, taking all of this in from all members in terms of the different questions, and certainly happy to follow up with others who are involved and are more apt to be able to speak to certain disease states and drill down on more of those specifics of where biomarker testing has been more successful as of today.
And then just to follow up, if I may, Chair. As far as these 13 states that currently, you said there were 13 states that mandate the biomarker testing, are they limited to oncology? Are they open-ended, or are they just kind of different, various, depending on the state?
So certainly, thank you for the question, and Zach Hardy for the record. Yes, so out of those states, I can say the vast majority of them are disease agnostic. So they go beyond oncology and cancer. But it certainly is a state-by-state basis. Each bill that has been presented there, may have been written differently, may have been more narrowed in scope, but the vast majority of those bills that have passed go beyond just limiting the scope of the coverage to oncology and cancer.
And do you know if any of those states, and if they do, if you might be able to help provide that information on do they collect data on the actual cost savings of those, I guess, providing that, like mandating that kind of testing, how much that is saving, I guess, the state in the long term? Or
yes,
even those
Zach,
providers?
Yes, Zach Hardy for the record certainly can take a look at, as I said, most of those, that number, the 13 or so states over the last, most of those bills were either introduced in 2023 and passed, or even this year and have passed in the last few months. But I do believe that some are tracking, the cost savings related to this. So I can certainly follow up with some information that may be available from some of the earlier states that have brought this legislation forward, and be able to share that with the committee.
Thank you so much. Any last minute questions before we close out this agenda item? I don't see any. Mr. Hardy, thank you so much for the conversation today. I think it's important to have at least this discussion. I know you mentioned that other states are looking at it, and I think that many of the committee members at least appreciate the opportunity to have these discussions before we go up for legislative session, just simply because of the nature of looking at patient care and access and making sure that patients receive treatment, but we also want to make sure that it's a fair assessment of treatment. And so I appreciate your presentation and for submitting the policy recommendation. We'll go ahead and close out this agenda item and move on to our last agenda item, which is public comment. If there's anyone that would like to provide public comment in Southern Nevada, Seeing none in Northern Nevada. And I think we do have a few folks in Northern Nevada, so if you can just keep your comments to 2 minutes, we'll start in Northern Nevada, and then we'll go to online.
Thank you, Chair. Benjamin Challoner, Alzheimer's Association. Just real quick, for Alzheimer's, based on a 2018 analysis, there was a projected cost savings of approximately $63,000 per person, of which $30,000 was Medicare, $20,000 was Medicaid savings, and $13,000 was for other savings in terms of early diagnosis, and this is in terms of biomarker testing. And so oftentimes we think of biomarker testing as blood samples, but that also includes CT imaging and anything that we can make sure that we are able to identify these specific biomarkers. And so with Alzheimer's, because it's the only way we could get that diagnosis right now is through a cognitive assessment. Sometimes by the time they're showing some cognitive decline, it's already too late to get folks into treatment. And so if we're able to get these biomarker tested approved specifically for Alzheimer's and other dementia, but we want to make sure it's approved for all diseases, we're able to get folks diagnosed up to 2 years sooner. So thank you so much.
Thank you so much. Anyone else in Northern Nevada? Seeing none, BPS, let's go virtually.
If you would like to speak in public comment, please press *9 now to take your place in the queue.
Hello.
Please proceed.
Hello, Chair and committee members. By way of introduction, I'm the clinical coordinator for the Truckee Meadows Community College. This is Dennis Nolan. I had retired last year as the EMS division chief for the Reno Fire Department. And prior to that, I spent nearly 30 years in Southern Nevada in EMS and the fire service. I wish to show my support for the need for adequate funding for the Nevada EMS program and the necessary change of its status from program to a bureau. These changes are needed to support Nevada's ability to provide efficient and effective emergency medical services. The program was created in NRS in 1973 when there was less than 100 EMS providers, and now they deal with tens of thousands of EMS providers and agencies in licensing and certifications. And if you review the National Registry of EMT's website that shows the state status, most states, including our neighboring states of Idaho, Utah, and Arizona, have EMS bureaus with divisions, sections, and offices populating the majority of the remaining. For decades, the program has been underfunded, understaffed, and undersupported. As a result, often the staff, which I found to be hardworking and loyal state employees, struggle to efficiently execute their mission. The effect to the fire departments and the private and volunteer ambulances and EMS providers, and to the educational institutions like CSN and not CSN, but TMCC and Western Nevada College, who are responsible for training EMS students, is service which actually interferes or delays with these various organization operations. One item that could relieve unnecessary and burdensome workload of the state EMS staff, and which could be affected simply through a letter of intent from the legislature or a committee, is the requirement for EMTs and AEMT students to have to apply for the same provisional licensing that all professional people do, just to do a one-time training ride-along. So the state requires this now.
Mr. Nolan, if you can please wrap up your comments.
Thank you. So I'll provide a written summary of my comments, but in summary, I know some of my colleagues had provided testimony earlier this morning. Just we need to work to support the EMS division, update it to the 21st century, and there's some suggestions in my letter to do that. So thank you for the opportunity.
If you have recently just joined us and you would like to participate in public comment, please press star 9 now to take your place in the queue. Chair, you have no more callers wishing to participate at this time.
Thank you so much. We'll go ahead and close public comment. Any other comments from our committee members? Seeing none, we'll go ahead and close out this meeting. Thank you so much for joining us. We'll see everyone for our April meeting. That discussion will be solely focused on public health, since it will be Public Health Day or Public Health Week, and so we're very excited. And if there are any residents watching, congratulations on matching this week, and we are excited to keep you hopefully in Nevada. Thank you so much, and the meeting is now adjourned.